We're taking this, 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 we're taking with a pinch of salt.
Welcome, ladies and gentlemen. Like the song says, we're taking things with a pinch of salt, trying to ask sensible, clinically relevant questions to provide you, our dear audience, with sensible, clinically relevant answers. All of this viewed through the goggles of a common sense perspective. My name is Andrzej Kubernet, and you're listening to A Pinch of Salt, a new ERA podcast series. It is an honor and a privilege to have as our guest today Dr. Elke Schäffner, who is a well-known expert in the field of CKD with a particular interest in the elderly population. Elke, welcome to A Pinch of Salt.
Hey, welcome to you.
Very nice to have you here. We're very grateful, especially because this is a huge subject and an important one. So the main thing we'll be discussing today is how to diagnose and interpret CKD in the elderly population. But before we do that, I would just like to share some thoughts on aging, specifically aging organs, and whether aging is normal or pathology, and if there's a difference. So let's take skin, for example, because it's the one organ you can visualize in its entirety almost. And as we get older, we all notice that the skin changes. And when you see an older individual, somebody who's 70, 80, might look very beautiful, but the skin is definitely different. And you don't find that to be abnormal or strange or wrong. It's just, older skin. But if you would see that same type of skin in a 20-year-old individual, you would be very, I guess, worried and thinking, what is wrong here? So in CKD, we just have one criterion for CKD, even though we know that the kidney ages as well. And it doesn't seem reasonable to have the same criterion for somebody who's 20, 50, or 80 or 90. So our first question is, should we change the cutoff value of eGFR below which we diagnose CKD in elderly patients, as some have suggested? There have been papers written. You've been a co-author on some of them. Should we change that? I think the CKD KDIGO guideline is coming up, and I'm not sure that that's going to be part of it. Should we change that?
It's going to be part of it. I can say that already.
Okay, breaking news, everybody.
I'm
you
not
heard
saying
it first on our podcast.
I'm not saying anymore.
Okay.
I'm just saying it's been a long and heated debate over the last 10 years. It's probably not totally over. Most debate in that context is on patients with CKD stage 3A without any albuminuria. That is actually the fraction that people debated about most. And here I have to say personally, I would be reluctant to call older adults as having CKD if they don't have any albuminuria and if they are in stage 3A. So we know that that the kidney function is not constant over the course of life. And at the age of, around more or less 40, the kidney function starts to gradually decline. And the decline generally starts rather mildly at a younger age, and then continues until old and very old age at a rate of 0.7 to approximately 1 mils per minute per year. And in contrast, and that's actually called, the senescence. So like the skin you alluded to, that's just normal aging, what we say. And in contrast to the gradually declining kidney function with age, the staging system you referenced to, KDIGO, for CKD severity has age-independent fixed thresholds, cutoffs. And if the GFR of a patient is below 60, then this is regarded as a CKD in young and old patients, so totally independent of age, which I think is kind of problematic. So if you, for example, compare a GFR of 60 in a 30-year-old, I think that's much more worrisome compared to a GFR of, let's say, 50 in an 80-year-old. And I think that's actually describes the problem quite well.
Yeah, maybe we should get into how we actually got to the number 60. I mean, where did that number come from? Because as far as I can tell, as far as I know, the idea was that the mortality rises when you get below 60. If you look at the mortality based on the actual glomerular filtration rate, it starts rising as you come below 60. But in the elderly population, that's not really true. It only starts to rise below 45. Obviously, if you don't have
Yes.
proteinuria or some other sign of kidney disease. So it makes sense that if you chose that number because it's a turning point for mortality, that you would choose another number for a different population for the exact same reason, because it's the turning point for mortality.
Yeah, exactly. There is, so to speak, a shift of cutoffs as you become older in terms of how you associate this cutoff with outcomes, future outcomes, which is actually laid out quite nicely in this Jason paper I think you're alluding to. Yeah, which is like a call for an age-adapted definition. Yeah.
Okay, great. Second question is, how should we assess kidney function in older people? Again, a bit of a problem. The large formulas, the studies that created CKD epi did have quite a large group of people, also some that were older than 70, but obviously not as large as the younger population. And with age, you don't just lose kidneys and nephrons, you lose muscle, and we all know that creatinine is a function of that. So is there anything new on how we should assess kidney function in older people, or do we just stick to the CKD epi formula for the time, the creatinine one, I guess?
I think first of all, it's important to acknowledge that estimating kidney function is not as easy as most people think. Why is that? I think the main reason is that the biomarkers we base these formulas on are suboptimal. Right? So, as you already said, we talk about the serum creatinine and serum cystatin C, and both are not ideal. And especially creatinine greatly depends on muscle mass, you said it. And that's problematic in old age because a lot of people lose muscle mass as they age, leading, we call it sarcopenia, and that leads to a very small, a small creatinine, which transfers to a falsely high GFR. So that can be greatly misleading. And then we have cystatin C. Some see it as the solution to all. I'm still quite reluctant to see it like this because it also is influenced by many variables. We call them non-GFR determinants. So inflammation, for example, is something that influences cystatin C. So when it comes to how to estimate kidney function best in older adults, what the data tell us is, and these data are quite robust, is that the best results are yielded by a combination of, so if you take a formula that's based on the combination of both biomarkers, creatinine and cystatin C. And that is actually, that can be seen across all sorts of, there are many formulas out there across all sorts of formulas. So if it's CKD epi or actually the European-based formulas called the European Kidney Function Consortium Estimation Equations. I'm actually a member of the EKFC consortium, which collects data from many European countries. And the EKFC equations have been published recently and show very, very good precision and very good bias, and especially if you combine these two biomarkers. Now, I know that a lot of people say, well, cystatin C is so expensive and we can't afford it. And probably it's not even necessary that you, even in old age, use these combined equations in every person. Of course, it depends on the situation, right? If your if your value or if your treatment highly depends on the GFR, so you really need a precise value, then you're probably well advised to use a combined equation, or even to measure GFR using something like iohexol, a plasma clearance, but that's probably less often available.
Yeah, definitely less often available.
And then we just have to be pragmatic. If cystatin C is not available because it is too expensive or the lab doesn't offer it or whatever, then you have to use a creatinine-based equation in old age. And then my advice is just do not take the value you receive from the lab for the total truth. So you have to, as your podcast say, you have to take it with a pinch of salt, because you have to take the value, but don't treat the value, but the patient. So take the value and put it into the clinical context of your patient. So if you have a sarcopenic patient, but you don't have cystatin C at hand, you have to kind of interpret the value you receive. That's actually the best you can do.
That sounds very reasonable. And also not forget about proteinuria, I guess, because that's also a problem. At least, I mean, in my country, obviously, in large hospitals, it's easy to quantify either in the 24-hour urine or as a ratio with creatinine. But in primary care, that might not be possible, and then it's pretty difficult to, I guess, assess what's going on with the patient without having proteinuria or just relying on the GFR.
Well, actually, similar problem, right? ACR is pretty simple to conduct, because you just, need a spot urine. But then again, if you have a sarcopenic patient, then your ACR will be falsely high.
Yeah.
So that's also something we as clinicians have to think about.
Yeah, precisely. That's a great point. So on to the third question. Now, risk of kidney failure in older people with CKD is vastly outweighed by risks of other events. There are very few who come to dialysis, luckily, I guess, or not, if it's because they died before. So cardiovascular events, early mortality, basically everything you would get with aging, but even faster. So who should actually look after older people with CKD, given that it's by definition almost a multi-organ disease? Kidney disease is never just kidney disease, I guess.
Yeah, some even call it a syndrome nowadays. Yeah. So that's an excellent question. And yes, it's absolutely true. There are what we call in epidemiology competing risks. So that means death or some cardiovascular event competes with kidney failure. And we all know, if you apply for example, the Tangri kidney failure risk equation, then we see that the majority of cases, in the majority of cases, the risk of really experiencing kidney failure and then subsequently requiring kidney replacement therapy is indeed very low. So does that mean that there is no need that these people are being seen by a nephrologist? No, of course not. However, I think, again, we need to distinguish between a mildly decreased kidney function without any albuminuria, for example, or other signs of kidney disease, and someone who has a positive ACR and already more advanced kidney function loss. And then, especially in old age, and that's the population we are talking about today, is I'm actually a big fan of an interdisciplinary approach, if that's possible, because I think everybody benefits from that. First and foremost, the patient, and secondly, also us as physicians, because we learn to take our perspectives from the other colleagues from other disciplines. Because especially in old age, it's a lot about what is important or more important than other things. So prioritizing treatment, what is my treatment goal in this particular older patient? And then, of course, someone has to take the lead. Someone has to take the lead and coordinate treatment. So I could imagine that's the GP if we only have a mildly decreased kidney function. If it's a more advanced kidney function loss, then the nephrologist will probably take over. There may also be geriatricians involved. I think it's just important to define, as a shared decision process, to define the treatment goal, and then have good conversations about what is needed and what is maybe not needed.
Yeah, I agree completely. I mean, I think we probably need to find some logistical technical solutions on how we would be more efficient in communicating between each other with primary care physicians, with cardiologists. Not right now, if we don't sit in the same room, it's like nothing happens. So I think even though we had COVID and there's a lot of Zoom talks and all that, I don't think we are applying that enough, I guess, into our routine practice, because as you said, when more people know more things and more perspectives are beneficial, but then like you pointed out, with multidisciplinary approaches, is who is going to take the lead. That's not
Absolutely. It's
that's not a
very
banal question. Yeah.
no, absolutely. It's very nice on paper, but then to do it and to take on that in practice is quite difficult. I'm just just one example that's coming to my mind right now when it comes to taking on different perspectives. I always remember talking to a geriatrician who told me, you know what, Elke, we don't care about GFR at all. Our big goal is to have the patient at home and to take him or her out of the hospital as soon as possible. And the first second I heard that, I thought, oh no, how can she say that? GFR is so important. But then I thought, yeah, she's right. I mean, that's the geriatrician perspective, and we have our nephrology perspective that is important as well, of course. And it's very, very nice and probably very effective when both of these perspectives come together.
Yeah, I agree. Sometimes I talk with the students, like it's almost like you have two types of nephrology for younger people and nephrology for very old and frail people.
Yeah.
And it's not being ageist. It's not, it's not that you wouldn't want the older people to get the care they deserve, but the goals may be completely different.
Exactly.
I remember a story from Atul Gawande, who wrote a book about dying and mortality.
He's great.
Yeah, he's great. He's great. He wrote about being working with a geriatrician, being exposed to that for the first time, and then this doctor was looking at a patient, and he saw that his patient, a female in this case, her toenails weren't done as well as they used to be, and he was like, "Uh-oh, toenails are not as good as they used to be. That means she doesn't stretch down, she doesn't scoop down anymore. She's not interested. Something is wrong. Something is not." And that has nothing to do with GFR, obviously, and probably much more with the patient.
Yeah.
Okay, we've really gone far with this one. Okay, but I think that those are really important views. Yeah, it's all about what the patient actually needs at the end. So fourth question, which might also be very relevant these days, is what is your view on SGLT2 inhibitor therapy in elderly and frail individuals? Because when we think about SGLT2s and we think about diabetes patients and overweight patients, it sounds great. They lose weight and everything, and they lose water and all that. But if you think about a very frail old lady, 86 and barely walking, is that really something you want to do? What would you say?
Very relevant question. I don't think I have a super definite answer. I think there's still not as many data explicitly investigating the efficacy and or effectiveness of SGLT2 inhibitors in old age yet. I recall a talk at last year's Kidney Week that has in the meantime turned, I looked that up into a publication where they stratified their analysis into sex and age groups and look at the effect of SGLT2 inhibitors also in old age. And the highest two strata are from 70 to 79 and then 80 plus. And if you combine these two, I think you sum up to approximately 1,200 patients. So that's not nothing, but of course, it's just one study, and maybe there are others out there. But this study then showed that there is a beneficial effect even in that high age in terms of a couple of adverse outcomes by giving SGLT2 inhibitors in that age group. So my personal view is I still think we need more data in this, actually growing population of older adults. From what I've seen and what I've heard, whatever level of evidence that might be, these drugs are very well tolerated. I haven't seen any big warning signs. What you just mentioned is very important, but I haven't seen any data on it. Maybe an additional beneficial effect I find quite tempting is the fact that these drugs do not aggravate hyponatremia. On the contrary, they actually help to make it better because hyponatremia is not very uncommon in old age. So that is actually something that is nice. So I guess if indicated in my parents who are above the age of 80, I would yes, I would probably give it to my mom and dad
Yeah,
if that
maybe
helps.
maybe we should take the geriatrician approach, and you give it, and if the toenails are still good at the follow-up visit, then it's fine, I
Yeah,
guess.
yeah.
Because I'm always a bit apprehensive when they, generally speaking, usually people define sarcopenia also by using bioimpedance,
Mhm.
and bioimpedance calculates muscle mass from the amount of water, and if you give something that
Reduces. Yeah.
will lead to less water in the body, I'm always wondering if this is really sarcopenia. So it's also muscle strength, I guess. Yeah,
Great.
so thanks. I'm really grateful for that you shared this thought, because I think that's important too. So fifth question. Okay. You're an expert in this field, as we have already established today. You have been following it for quite some time. So if you had the chance to give only one message to a young up and coming nephrologist, like one idea, one basic thought, what would that be?
So if I have to burn it down to one message, I would probably say do not treat numbers, treat the patient. And what I mean by that is what I said in the very beginning. Do not just take a number you receive from the lab, for example, a GFR value. Do not take it for granted or for totally real, but put it into the context of the patient and its his or her clinical characteristics. So basically use your clinical judgment. Do not lose it, use it.
Yeah, that's a great message. Don't treat the numbers. I was right now reminded of a patient that I got into our outpatient clinic. She was about 89 and her creatinine was 400 micromoles per liter, or was it 500? And she just changed her primary care physician, and she took the lab results and just got scared of it and just sent it her forward. And then I realized that she was already hospitalized in our clinic 5 years before that with 500 creatinine.
Mm.
And I would have never guessed that she would survive that
Wow.
that long. And I asked the lady who was there, her relative, what is your grandmother eating? I was
Mm.
interested in. She said, well, just a bit of soup and some cookies, which is not
Wow.
really guidelines, right? So, and then she said, do you think we should change that? I said, no, God, no. No, I think she's doing great.
I
Uh,
would have said exactly the same. Yeah.
yeah, yeah, yeah. Forget about protein, everything. Cookies and soup. That's great.
Mm.
Um, yeah, okay. Thank you. Thank you. Thank you very much. And now we're back. We're done with the heavy part, or maybe we're getting into the most heavy part. Depends
Oh,
how you see it, which is the sixth and final getting to know you question, which is which book, luxury item, and two songs would you take to a desert island and why?
yes, that is definitely the hardest one of all questions you asked me. Um,
Yeah, don't worry, Elke. We're fine. Whatever you like is fine.
whatever I like is fine. So book-wise, there is a great book. Don't make me don't make me give the plot, but I remember it to be a great book, and it's probably a book you can and you have to read several times. It's called Middlesex by Jeffrey Eugenides. I think that's how you pronounce the name. So
Okay.
Middlesex, for everyone who hasn't heard about it, that's my great recommendation. It has several levels of storytelling, so to speak, and it's actually quite appealing if you're a physician as well, because there is a lot of medical context, nicely embedded in much more in history. So a lot.
Interesting. Never heard of it. That's
Yeah,
that's great to know.
yeah, yeah. And music wise, I'm a big Amy Winehouse fan. So
Oh,
so if I have
we're
to
all big Amy Winehouse fans,
see, so
I guess.
so Our Day Will Come is great, and I'm also a Coldplay fan, so I would probably go for The Scientist. Um, but also some classical music, I suppose. Yeah, so Schubert,
Some Schubert. Oh, okay,
Schubert.
romantic. That's nice. Schubert
Yeah,
is very
very
nice.
romantic.
Yeah,
And of
yeah.
course, no other luxury. I don't need any luxury. Maybe my piano, but if there would be room on this island.
Well, definitely, it's all in your mind. So the piano
Yeah.
is there, I guess. Yeah,
Okay.
sure, sure. Fabulous. Okay, that's great. We've arrived to the end. Thank you, Elke, for joining us in a pinch of salt. We're very grateful that you have shared your valuable experience and insight with us. Thank you.
That was fun. Thanks a lot. Very welcome. Thank you all.
Exactly. Same here. Ladies and gentlemen, thank you for joining us and listening to this episode. Please check out other episodes that are already available and stay tuned for new episodes, which will be released every second Thursday of the month. Farewell.